Welcome back. Our next speaker is Dr. Nicola Brunetti. He's an associate investigator in the molecular therapy program and a professor of medical genetics in the Department of Translational Medicine at the University of Naples, Federico II, Italy. His specialty is understanding the pathogenetic mechanisms and developing novel treatments for genetic diseases. And he is actively working in the clinic and in the laboratory. He identified several novel genetic syndromes such as 1q21, deletion and duplication, 7q11.23 duplication, and BIS syndromes. His major research effort has been focused on investigation of gene therapy and small molecules for therapies of genetic diseases. His laboratory has been involved in preclinical studies to support the efficacy of small molecule-based therapies for maple syrup urine disease, pyruvate dehydrogenase deficiency, urea cycle disorders, and Myhre syndrome. As a clinical investigator, he is currently involved in phase 1 and 2 liver-directed gene therapy clinical trials. His research activity has been recognized by awards of the American and European Societies of Gene and Cell Therapy. So let's all welcome Dr. Brunetti, who is going to speak on skin and joints, stiff skin and joints evaluation and therapy. Welcome, Dr. Brunetti.
Thank you very much. Thank you for the nice and long introduction. It's a pleasure to be here. And I enjoyed the conference very much so far. We'll start with my presentation. Please let me know if you don't see the slide. As mentioned, I'm a pediatrician and geneticist, and but also do have a research lab. And really, in a few words, the goal of my research in the lab is to develop new treatments for genetic diseases. And I don't need to give much of an introduction on Myhre syndrome. You heard a very nice presentation on several of the features of this disorder. But I just want to highlight that this is really, Myhre syndrome is really a connective tissue disease, and therefore joint and skin, which are made mostly by connective tissue, are affected. And this would be one of the main topic of this presentation. You also heard quite a bit on the defect that is responsible for Myhre syndrome, that is this SMAD4 mutation that results in increase in the TGF-beta activity. And there is a group of diseases that are mentioned here. We don't need to go through all of them to this complex slide, but just to mention that there are other diseases that are due to increase the TGF-beta activity. One of the most famous of this disorder is Marfan syndrome. And there has been quite a good amount of work done on Marfan syndrome, elucidating the role of the TGF-beta increased activity in the pathogenesis. Here is the defect in Myhre syndrome, it's SMAD4, and my interest in Myhre syndrome really started with a patient with Myhre syndrome that I diagnosed actually when I was still a fellow in pediatrics. And back then, the gene defect was not known, but we got the fibroblast of the patients because we wanted to find out back then the defect underlying the Myhre syndrome. And our goal back then was to try to see whether we can identify the gene responsible for Myhre syndrome by looking at some of the phenotype of the cells of a patient. But then, as you heard later on, Valérie Cormier-Dary found the gene, and then we were able to after she found it, we went back on the DNA of that of the patient, and we found that patient who had the SMAD4 mutation. But we got the fibroblasts from the patient, and also in the following years, 2 more patients, we were able to obtain fibroblasts, and we started to look more in depth into the pathogenesis of this disorder, and particularly we focused on the extracellular matrix, and we find something that I guess is will be now quite expected, that there is a defect in the deposition of the extracellular matrix in fibroblasts from Myhre syndrome patients. So the MS1, MS2, and MS3 are 3 independent cell lines, skin fibroblasts from 3 independent patients. And the WT is the wild type control. I think it's quite easy to see that there is a clear difference in the amount of fibrillin-1, which is an extracellular matrix protein, in the 3 cell lines from patients with Myhre syndrome as compared to the wild type. And here on the graph, on the bar graph, you can see the quantification of this of the defect in the extracellular matrix deposition. We also noticed that cells of Myhre syndrome have an imbalance between proteases and protease inhibitors. There is more expression of genes responsible for proteases and less of the inhibitors of those proteases in Myhre syndrome fibroblasts as compared to the wild type. This is a feature that is expected from hyperactivity of TGF-beta that we know now is involved in the pathogenesis of Myhre syndrome. So what is also known, particularly from the study done on Marfan syndrome, is that there is a drug that can inhibit the activity of the TGF-beta receptor. So the receptor to which TGF-beta binds, activating an intracellular cascade that eventually leads to hyperactivity of the whole pathway. And therefore we asked a very simple question, whether we can also use Losartan to improve that phenotype, that features that we saw in the fibroblast of Myhre syndrome patients, that defect in the extracellular matrix deposition. And again, we performed a relatively simple experiment. We incubated cell lines from Myhre syndrome patients, the same one that I showed before, with either a vehicle, which is called the DMSO, or with the Losartan. And we also had a control, a wild type cell control that was treated with the DMSO or Losartan. And I think you can appreciate from these pictures that the patients, the MS1 and MS2 fibroblasts, so these are fibroblasts from Myhre syndrome patient, have a better deposition of the fibrillin-1 following Losartan incubation. In the wild type, you don't see much of a difference because really there's no defect there. And so these experiments suggested us that we can repurpose, so we can Losartan, which is by the way, a drug, I forgot to mention, is a drug that is given as a blood pressure medication. We can repurpose, then we can use the Losartan, approved for another indication for treatment of Myhre syndrome. But before even considering a treatment, we need really to make sure that we can follow something that is meaningful, some endpoints that are meaningful, and to make sure that the drug is having some effect. This is something that Valérie explained in her talk before. So, clinical endpoints are important to if anybody is developing any type of trial, because those endpoints are needed to establish whether any treatment is having any efficacy. And we started from a small group of patients that we could with Myhre syndrome to first identify clinical endpoints that could be used for a clinical trial. So here are 4 patients that we evaluated. They are both females and mostly females and 1 male of different ages, all carrying the recurrent SMAD4 mutation, and with some of them, actually most of them, had heart involvement and other features. But starting from these 4 patients, we first evaluated the skin thickness. Actually, for finding the clinical endpoints, we looked at an autoimmune disease that is systemic sclerosis. That is an autoimmune disease that has features of skin thickness and reduced joint mobility. And we adapted those scores developed for that disorder in Myhre syndrome. So the Rodnan score is a relatively simple measurement that is done by pinching the skin and looking at the wrinkles on the skin. And there are different scores. As you can see, for example, in A, the skin is more elastic, and but in B, C, and D is progressively less elastic. Actually, you don't see the wrinkles when the skin is pinched here. And this score can be calculated, can be assessed at different sites, and to have a final score. And here we have 5 controls that are matched for gender and age. And then, as you can see, the 5 controls have very low scores, whereas each of the patients that is labeled here as S1, S2, S3, and S4, they have much higher scores at the different sites. So in panel B, it's a summary with a heat map of the scores at the different sites in the control, in the subject 1, subject 2, subject 3, and subject 4. As you can see, if you look at the sum of all the scores at different sites, the patients have increased in the Rodnan score. Next, we evaluated the range of motion by a goniometer, which is typically used by rheumatologists to for an assessment of the joint range of motion. And here are again the control in white at the different sites. And as you can see, the patients labeled as S1, S2, S3, and S4 in the different colors, they all have a reduced range of motion. And again, here is a heat map with the summary of this finding, showing that there is a reduction of the range of motion in the 4 evaluated patients. We next also, with the help of the cardiologist, we evaluated the heart strain, which is a measurement, a very indirect measurement of cardiac fibrosis. And so it's done by a regular echocardiogram, but that has a specific applications to look at the strain. And this is by these measurements you get a score that is in controls is typically around 20, and we could evaluate at different regions of the heart the strain that was reduced in the 4 patients. And when you look at these images of the speckled tracking echo, you see areas in red that are areas that are more similar to the control, while the area in blue are the ones that are having less reduced score. And indeed, we did find the reduced score in some of the patients. For once we established these endpoints, we next decided to start the Losartan in 3 out of the 4 patients, S1, S2, and S3. And this was really prompted by one of the patients that needed a blood pressure medication. And by speaking with the cardiologist, this is patient S1. We decided to start Losartan as an antihypertensive medication. And this gave us the opportunity to start with S1 and see what were the outcomes in terms of skin, joint, and heart. So in here is following this 6 and 12 months of treatment with Losartan. You can see here the Rodnan score, that that is calculated is a measurement of the skin thickness, and at the different sites. Again, for at different time points, which is 6 and 12 months for the 3 different patients. So it's relatively complex because there are lots of bars in each of the graphs corresponding to each patient. But in the graph shown on the right, it's a sum of all the scores at the time 0, so before starting treatment, at 6 months and 12 months. As you can see, there is a reduction in skin thickness as measured by the Rodnan score in the 3 patients. Also, here is the range of motion for the 3 patients, calculated by the goniometer again at the different joints. And there are some, for example, in S1, there are some joints that are not changing much the range of motion, but there are others in which you can see some improvement. In S2, there are also improvements in some of the joints. And similarly, in S3, there are most of the joints that were evaluated were improving in the range of motion. And on the graph on the right, you can see a summary of those measurements. And there is the scores clearly are showing an improvement in the range of motion at 3 different time points evaluated. Also, we look at that speckle tracking echocardiogram, and in some of the areas that, for example, the ones that is highlighted here with the arrow that had a reduced strain, we could see that 6 months post-treatment improved. Some improvement was seen in all 3 patients, although in different areas of the heart. So the conclusions that we could make are that we have some clinical endpoints, such as skin thickness, joint range of motion, and cardiac fibrosis, that could be useful to monitor the disease progression, even without, even in patients that are not receiving any treatment. It could also be used as endpoints for monitoring the efficacy of the treatment. And indeed, the preliminary results shown by our pilot study show some improvement in the skin, joint, and cardiac abnormalities. However, I want to make very clear the point that this was really a pilot study with several limitations. One of the limitations that this is an open label, non-randomized and without a control. So that means that the investigators, so so ourselves, were not blinded to the treatment. So we knew that the patients were receiving the treatment. And there was no controlled group, and the best design for a clinical study is to have a randomized, controlled, double-blinded study, because that is the study that reduced the bias of ascertainment and of investigators, and offers the best evidence possible of efficacy of the trial. And this is really the study that should be performed, and to show that the treatment, including Losartan, is effective. And for this reason, at this point, we are not recommending treatment with Losartan to all patients with Myhre syndrome unless they are included in a study. But we hope that this study could be performed soon to provide this important evidence of efficacy. And with that, I would like to acknowledge the people who contributed to this work, particularly Pasquale Piccola, that performed the preclinical studies in the cell of Myhre syndrome patient, and Gerarda, she's here in this picture with Carol, our Myhre syndrome little girl. And Gerarda is really the driving force of the clinical, the pilot clinical study that I showed. We'll also to thank all our patients that participated. Here is Andrea, one of our oldest patients that is participating to a fundraising event, and also Teleton Foundation that has been funded by my laboratory, and our cardiologists, of course, also. And I thank you also, all of you, for your attention. And I will be glad to take questions.
Thank you so much, Dr. Brunetti. You have a high interest subject, both joints and Losartan, so you have a lot of questions. First question is, do you see lower limb issues or bone dysplasia commonly in Myhre?
Not much. Typically, we do see short stature. That is a feature of several skeletal dysplasias, but with not particularly disproportioned.
Okay. Next question, keratosis pilaris, sometimes called chicken skin. Is this a common Myhre symptom, and how do we treat it?
I've not seen that much. I don't think there is any need of a treatment for that.
Okay. All right.
I can just mention, so tomorrow's talks will be complementary to this. So when I do my MGH clinic, Nicola, I have some data about that feature.
Great.
Okay.
Thank you, Dr. Lin. What is happening when the skin is trying to heal and scarring happens? Is there extra or too much function there so it scars more easily?
Yeah, that's a great question. Obviously, there is always the fear of an over fibrotic reaction. This has been reported, and this is also the reason why we heard also from previous talks that any surgical intervention needs to be done with need to be considered with extreme caution. But we have also had one patient in which is actually scarring has been an issue. So actually, the wound healing has been extremely prolonged. And actually, I'm still unclear on the reason, on the defect underlying this wound healing, at least. It seems to be sometimes too much. And at least our little experience has been extremely delayed.
Okay, thank you. Next question, joints. Do physical therapists need to be careful about joint stiffness? Example, not go too far in manipulation.
Yeah, I think that is an issue. I think I would not recommend, for example, too strenuous, too energetic physical therapy. I think this could be problematic.
What is your opinion on casting, the sequential casting to increase range of motion, especially in the ankle, when people toe walk and their ankles get tight? Do you have an opinion on that?
to say something that is evidence-based, honestly. I don't think we have enough. We know enough to say whether there is any contraindication to that. But no, I will discuss. This needs to be discussed with the physical therapist and in the context of any specific patient, I think.
Okay, all right. Will early onset arthritis be something we should be aware of?
Well, reduced range of motion would be definitively something that patients with Myhre syndrome can develop. It's not in the form of the arthritis that it's typically seen with rheumatoid arthritis, for example. I think it looks like being a different type of joint problem without the inflammation, the redness, and the pain that is typically with the arthritis.
Nicola, do you mind if I just supplement what you've said? I agree completely that what we called arthritis in Myhre syndrome is not the destructive joint arthritis we see in other types. It's not like osteoarthritis. Now, granted, this is based on small numbers of adults, but we've done MRI studies and we don't see destruction. And it's, as you say, it is remarkable. It is external. It is skin and connective tissue that limits the joint mobility, and is seen as young as some teenagers. I'm sorry for interrupting. I thought you.
Thank you, Angela. I think that was a great comment.
Thank you. Yeah. So how do we help keep our kids' skin and joints as healthy as possible?
Well, as far as the skin, I don't think there is much that can be done to honestly. I will not recommend overexposure to sun, for example, but I will just follow the general rules that any other kids should follow for protecting the skin from sun exposure. But there is not much else that can be done. As far as the joints, obviously, any exercise that are that are excessive and particularly with the loading of joints probably is not a good idea. It would be probably better to have to perform sports like swimming, in which the joints are not it's less of a burden on the joints, for example.
Okay, all right. So now on to Losartan. Is it wise for all Myhre kids to try Losartan? Are there any downsides?
Well, if you're taking a drug, there would be there could always be side effects, of course, and I don't think it would be a good idea to have Losartan given to all kids. Although Losartan is a safe drug, there is extensive data that's showing that this is a drug that can be given safely. You want to give a drug when you know that the drug is having some effect, and we don't have that evidence yet. But hopefully we will have it in the future, and then once we have it, obviously there will be no reason for not giving it the Losartan.
Okay.
Also, to make another comment on Losartan, obviously there could be aortic stenosis would be a contraindication for the Losartan sometimes, because of course. So it also needs to, if anybody is considering Losartan, I will recommend it to do it within a study, but also the cardiologists need to be well aware of the treatment and supportive of the treatment.
Can you explain that a little more? Why coarctation of the aorta would be a concern in giving Losartan?
Yeah, because the Losartan will reduce the blood pressure, and if there is aortic stenosis, obviously there is already a reduction in perfusion systemically.
Okay. Okay, great. Okay, so the next question, do you think the phenotypic differences seen in Myhre syndrome patients are due to the specific mutation that each patient has, or are the differences more due to variable penetrance or a combination or something else?
Well, with Myhre syndrome, we have actually a relatively rare and unique situation in which most of the patients are carrying the same mutation, right? But there are many genetic diseases in which there are lots of different mutations that are having a different impact on the function of the protein. This is not really the case with Myhre syndrome. As we heard, most of them are carrying the same mutations. But in any genetic disease, there is always a mild form, a moderate form, and a severe form. And actually is even more than that. There is typically a spectrum. There are also forms that are in between the mild and the moderate, between the moderate and the severe.
Okay, great. Okay, so the next question is, should a Myhre patient take a different antihypertensive consider switching to Losartan?
Well, again, during my talk, I mentioned one of the reasons that prompted us to start the Losartan. So our patient needed a blood pressure medication, and we discussed with the cardiologist the possibility to give her Losartan. If there is the need of giving a blood pressure medication, I think it would be reasonable to discuss with the cardiologist the option of the Losartan instead of another one, given that there is no contraindication to the Losartan.
Okay, great. Let's see. They keep coming. How best to get a happy medium with joints? I like to run, but I'm slow due to joint stiffness.
I'm not sure I got the question right. So the question is how to keep the joint.
Maybe they want to keep active, but it hurts to. They like to run, but it hurts. So just want to know how to.
Running will not be particularly if it is heavy running will not be the best type of physical activity for because of course particularly heavy running is a burden on the joints, and probably I will have a more an approach that is more prudent, try not to have a heavy burden on the joints.
Okay. My daughter is 4 years old, autistic nonverbal. She walks a little and wants to sit. The person wants to know, how can she tell if it's because of joint pain? That's a hard one. It sounds like it's hard for her to know why the child wants to sit down and not walk. Is it because of joint pain or something else?
Well, as we discussed, probably pain is I will not think it's a pain, but it's probably the joint limitation that because pain is not, at least to my experience, does not appear to be common in joint pain, at least.
Okay. All right. Just a couple more. This person's joint condition is arthrogryposis.
Yeah.
Is it common in Myhre?
Well, I don't think so, actually. And I will ask also to Angela whether she has seen any patients with arthrogryposis. I'm not seen any patient, but I'm not surprised that there would be this is a feature.
So we should define it for everybody. Arthrogryposis means multiple congenital contractures. It's a description, it's not a disorder. Some patients with Myhre syndrome when they're younger do present with multiple contractures, but we do not use that designation. I could be wrong. Maybe there is somebody out there who has it. The contractures are fixed, which is different from Myhre. Thank you.
Thank you, Dr. Lynn. So it looks like one more question. Can limited mobility in the neck and spine be reversed?
Well, that's a tough one. At some point, I will say that it depends on for how long that limited mobility has been there and how much structured is the limited mobility. Obviously, more advanced is the limitation and more difficult will be to reverse. If it is at the early stages, there could be some potential for improving it, but not much at later stages.
Okay.
Folks, if I could just say something, I know this is such a wonderful opportunity to ask the experts, but you have to realize it's very difficult for us to give a talk and then to be put on the spot. We want to help you. We know you want answers right now, but it's very hard to do that. So nothing that we say in this kind of context can be taken and saying, Dr. So-and-so said, go do this. We're trying to really reflect on a general talk, his research, and trying at the same time to be courteous to you, but be very careful about our good intentions in trying to answer questions. Thank you.
Thanks for clarifying that, Dr. Lynn. So that being said, I want to thank Dr. Brunetti for his great talk and being patient with us and all the questions.
My pleasure.
All right.
Do I have time to ask a question?
Sure.
So first of all, I want to congratulate Nicola. What he has done is amazing. I hope people can understand how much it takes to think, plan, and execute a research study, no matter how small it is. So I congratulate him. And he's also positioned in the right milieu to be thinking about repurposed drugs or even novel drugs. So that's great too. So here's a fun question. If you could write a wish list for how much money you would need to conduct a multi-center, multinational drug trial, and let's say that your goal of N would be something reasonable, not 100, let's just say 50. What do you think it would cost, Nicola?
So
you're the brave person who started this, and we admire you for it.
So excellent question. And actually, I've been making those calculations. Obviously, the more centers you have, the more expensive is the trial. So ideally, and also if the sites are on different continents, it's also getting more expensive. The drug is very cheap, so that's an advantage. But I've been actually more thinking of doing it between 3 centers in Italy. We will probably be able to enroll something like 10 to 15 patients. And the cost of doing something within Italy with the 3 centers, it's not that much. It's in the order of 50,000 euro to 70,000 euro. The cost for doing it as an international will be clearly higher than that. And the more centers you add, the more expensive we'll get. But the more international it is, the more centers you have, the better it's going to be the trial.
Well, I think what you say makes complete sense. And I do think it helps for listeners, providers, and patients and families to hear an amount, euros or whatever. So when you do think you have those calculations, you can certainly present it to the professional board, and then we can disseminate it to the parents too. But I think it helps to have that target. Mm-hmm. So congratulations, good luck.
Thank you.
Yeah, thank you.
I could just make a comment about physical therapy, a generic comment. Physical therapy means different things to different people in different places. It's not just range of motion. I love physical therapists. I think they do great things. They start with a baseline, they calibrate, they follow, and they do more than just range of motion. They look for balance. They do a lot of different things. Some physical therapists that I work with now, Nicola, we're exploring the idea of sort of muscle massage, deep massage for possible fibrosis, the pseudohypertrophy, that's also just a venue. So it's very broad. The notion of casting, immobilizing is not something that I have experienced or I would do. Some children do need orthotics, which is something, made out of plastic or something. How do you feel about that, Nicola?
Again, this is an area where typically evidence are very little. But no, most of the time, at least myself, I go with the common sense. I think doing physical therapy is important, and it's not only range of motion, not only mobilizing joints, but doing something more than that. I've never heard about that muscle massage, but
it's just a hypothesis that's 1 month old, so we're just thinking about it now.
Okay.
Sophia, did you want to add something?